This is a 22-year-old female with a pigmented lesion on her left cheek. It's been present for years, but recently enlarged and darkening. There's no personal or family history of melanoma. On facial skin, we see a compound, predominantly junctional proliferation of melanocytes. The lesion shows dysplastic features, namely a hyperplastic epidermis, fibroplasia around the rete, and bridging of junctional nests. Dysplastic features on facial nevi is considered highly atypical. There's pagetoid scatter of solitary melanocytes. The dermal component is bland and well-nested. IHC stains, MART and MITF stains were performed to highlight the melanocytes. PRAME was not commercially available at the time this case was being worked up in 2018, but a retroactive PRAME shows positivity in many of the cells in the junctional component. A melanoma on the face is unusual in this age group. For this reason, this was reviewed at consensus conference to get as many eyes as possible on the case. And the best we can do as a team looking at this case together was to sign it out with a preliminary diagnosis of this is a compound melanocytic proliferation with severe atypia. This was reviewed at consensus. The histologic findings represent a compound dysplastic nevus with severe atypia, although in this location, dysplastic nevi are considered highly suspicious for melanoma. If there's a history of a prior procedure or a trauma at this site, some of the features can be attributed to recurrent nevus phenomenon, that is pseudomelanoma, but if no such history exists, the possibility of melanoma in situ arising in a nevus cannot be excluded with certainty. And so this is what's reported to the clinician. And I can tell you as a dermatologist, that is a very unsatisfactory report. What do you tell the patient? She wants to know, do I have a melanoma? And the provider wants to know, does she have a melanoma? So it was sent for MyPath, and it came back with a score of positive 1.5, suggestive of malignant neoplasm. So in this young patient, this molecular result allowed us to render a final diagnosis of early melanoma in situ arising in a nevus. And the combined histopathologic and molecular findings support this diagnosis. So as far as treatment goes, she had it treated with slow Mohs excision. That means a staged excision that's performed to get a 360-degree marginal view on FOSS margins. I feel good knowing that in this patient, I made the diagnosis of melanoma in situ with the full backing of molecular testing results showing that her tumor was behaving more like a melanoma than a benign neoplasm. I don't think that she was overtreated in this case. I think this was an appropriate treatment for an early melanoma in a young patient.